If you want to stay standing, that's fine too. All right, perfect. Very good. Well, welcome to all of you to Banff. As you realize, the weather is wintry. That took a lot of organizing to do. And we weren't sure whether we would actually be able to arrange that for you. I'm Ari Sharma. I'm the scientific director of CON. And I just want to, but just by show of hands, how many of you have been to an obesity summit before, the Canadian Obesity? That's quite a few. Well, all of you, welcome back. This is the fifth one. Those of you who've never been to an obesity summit, I think you're going to be in for a very interesting time. The Obesity Network, just a couple of words of introduction here. It's been, can we get the slides on the screen rather than the picture here? All right, and move back one slide. Great. So the Canadian Obesity Network, as many of you know, because I can see many folks in the room who have been part of the network from day one and part of how the network started. It's been 10 years, so this is actually our 10th anniversary of the Canadian Obesity Network. Again, as a reminder, what the network does, our mission is to improve the lives of Canadians affected by obesity. And by affected by obesity, it's not just people who are living with obesity, but everybody is affected. And if anybody close to you has obesity or is living with obesity, then I could almost predict that you're in some form or fashion affected. Our vision, and I think we've achieved that vision, is to be Canada's authoritative voice on evidence-based approaches to obesity prevention and treatment, management, and also policy. And I think we've managed to do that in the past 10 years, and our goal now is to sort of keep doing that and continue being that recognized voice. It's a pretty large organization. It's literally a network, and we have a lot of people who've been joining the network and continue to join the network. There's now over 15,000 members who are registered on our website, and these are all the professional members. It's not the public, and I'll get to the public in a minute. So this actually officially makes us the largest obesity organization of any country in the world. There is no other organization that's as big as this at a national level. The network, as many of you know, has been very much top-down over the many years that it's existed, and that largely was a staffing issue, and there was also an issue about, let's get things started. But recently, and in fact now since 2 years, we've started having local chapters, and we have local chapters, as you can see on the slide. There's a whole number of them, and they're just amazing. I mean, these local chapters, they are locally networking. They're doing events. They're doing all kinds of activities there, and if you're in one of those cities and haven't connected with your local chapter yet, then please do so. If there's anybody in the audience who's asking, well, why is there no local obesity chapter in my city? Well, then come talk to us, because there's opportunity. There's a whole playbook on how you go about opening your own chapter. So if anybody feels inspired and says, well, we want the same, then talk to us, and the network will be happy to support that. Those of you who've recently visited the website probably in the last year and a half or so would have noticed that there are now two options when you get to the website. You've got the professional option, which is what we've always had, which is professional members, people who have a professional stake in obesity. But what you'll also notice is you have what we now call the public website. And that's a new aspect, and this was really launched shortly after we had our last meeting, the last summit in Toronto. And the background for this is really that CON has taken on what we now describe as public engagement. And public engagement is where we've really reached out to and are engaging Canadians living with obesity, really in all aspects of running the network. This goes from all of the activities that I'm going to talk about that the network has been doing, and you will see many of the members of the Public Engagement Committee. They've already been hard at work. They all got here on Sunday. They've already had 2.5 days of full-day strategic meetings, and they're very excited to be here. And you're shortly going to hear from the chair of the committee. And so I think it's really, really important that when we talk about the science and we talk about the practice and we don't forget who it is that we're actually talking about. And the Obesity Network has taken this mission very seriously to really give a voice to and ultimately perhaps also be the voice of Canadians living with obesity. Now, having said that, as you probably are all aware, the Canadian Obesity Network has a lot of activities going on. We continuously roll out all kinds of education events, be they online or in-person meetings, certification courses, CMEs, dietitian retreats. We partner with a number of organizations to keep CMEs going, and professional education, lots of stuff going on. You're probably also quite aware of the whole suite of tools that have been developed over the past years. You've seen the 5 ways of obesity management. We now have that for adults. We've got it for pediatrics. We've got it for weight gain in pregnancy. We constantly get requests to the CON office to get these. In fact, some of these are now also available in French. We have the 5 ways of obesity management also available in French now. Just as a reminder to those of you who perhaps don't know this, that the Edmonton Obesity Staging System, which is now actually finding adoption in a number of guidelines in a number of different countries, there's now also a pediatric version of this that was launched by a working group that put together by CON. And if those of you who work in the pediatric field haven't seen that before, this is just a reminder that you can actually see that pediatric tool. We're also very excited at this conference to be launching a new program by the Canadian Obesity Network here in partnership with Novo Nordisk. And that is going to be a program of certified bariatric educators. And what this is really aimed at are folks who are allied health professionals, and this includes nurses and dietitians and other allied health folks, working in the field of obesity or wanting competency in the field of obesity. They can now acquire this certification. It's not easy to get. There's a lot of, when you look at how you have to get it, you have to attend a lot of CMEs. There's lots of knowledge that you have to accumulate, which will then be tested in an actual exam that you would have to take. It's a program, if you want to find out more about the program, what the curriculum is, and how you go about becoming a certified bariatric or a bariatric educator, stop by the Canadian Obesity Network booth and you'll find out more about this program. We wouldn't have a meeting like this if I didn't talk about all of the activities that CON has always been doing in the area of career development and supporting the next generation of obesity researchers. CON SNPs, the term stands for Students and New Professionals, and this has been one of the key activities of the network from day one. What you see on the picture is the national executive. The way the CON SNPs run, and sometimes we call them the SNPpies. What they do is they work at the level of various educational institutions across Canada, and I believe there's now 26 independent chapters, and they have a national executive, and they do a lot of things. It's just absolutely amazing to see the enthusiasm and the work that goes on across the country. And this is just one example of the activities that the CON SNPpies are undertaking, is the mentorship matching program, where they're looking both for mentors and they are looking for folks and they are looking for folks here who are willing to take on folks who are early in their career development and mentor them through this whole process. And we always talk about the fact that there are many, many job opportunities, many, many career opportunities in academia, industry, government, non-for-profit, clinical sectors, etc. I was briefly at the career development workshop this afternoon. There was a whole panel, again, organized by the CON SNPs. And so if anybody thinks that they know or would have any interest in mentorship, or if there's folks who are in early stages of their careers looking for mentors, well, then this is probably the program that you want to find out more about. Okay, having said that, one of our flagship activities continues to be the so-called CON boot camp. Now, the boot camp, we've changed the name because people didn't really know what the boot camp was, and people were always asking, are you going there to lose weight and exercise? And people thought this was like CrossFit and stuff. Well, you went to the boot camp, but you don't look any different. In fact, to be honest, people gain weight at the boot camp because the food is so good. So we've renamed it. It's now called the Summer School, and there is going to be one this year. I think the opportunity to apply for those seats is still there. How many boot campers in the room? Oh, yeah. Bunch of them. There's 270 of them now. And I can tell you that out of the 270 people who over the years have attended boot camps, 40 of them now have faculty positions across the country. Not just across the country, actually. One of our boot campers is now an assistant professor at the Harvard Medical School. So coming to boot camp, being at boot camp almost guarantees that you have a career. So think about it. Okay, so since the last meeting in Toronto, a lot of things have happened in obesity across Canada. One of them, one very notable one, was the launch or the release of this report from the Senate committee last year called Obesity in Canada. This was sort of a whole of society approach to a healthier Canada, and obesity, of course, was one of the central points addressed in this. And if you read the report, there's 21 recommendations, and they're all good. All of those recommendations are excellent. But they all focus on prevention, which of course is important, and which of course, if you think about the way the Canadian health system works, that's what the federal government does. They do population health, and there's lots of very good recommendations there. And those of you who haven't looked at the report have to look at, should probably want to look at it. What I haven't seen happening is that a lot of those recommendations now actually transfer into policy, and I know that government doesn't do things fast, but if even half of those recommendations actually became policy and got implemented, I think it would make a real difference in terms of obesity prevention. No doubt about that. Now, having said that, here's another major development that's happened in the last years, or in the last couple of years since the Toronto summit, and that is that the Canadian Medical Association had put out an official position statement where they declared obesity to be a chronic medical disease. Now, this is something that folks in the Canadian Obesity Network have been saying for a long time. There's a number of other organizations that have been saying this for a long time. When you look at obesity, it behaves like a chronic disease. Once you have it, you're pretty much stuck with it for life. You can treat it, you can manage it, you can do what you want. But I personally, I've been doing this for 25 years. I've never cured anyone of their obesity. And that's not to say I haven't had successful patients. Of course, I've had successful patients, but you really do need to take a chronic disease management approach to obesity once you have it, for whatever reason you have it. And so one of the questions then, of course, becomes, if you have obesity, if you call obesity a chronic disease, then first of all, the question, well, how common is it? And when we look across Canada, just using BMI definitions of obesity, and I'll talk briefly about what the issue there is, then there's no doubt that we are seeing a lot of obesity across Canada. We have about 6 million Canadians currently living obesity, both adults and children. What you see here are the numbers of adults, and these are data from 2014. Not much has changed. We could say at a population level, the levels are kind of stagnating in the sense that they're leveling off, which is great. But what we are seeing, and this is of great concern, particularly to people who work in the healthcare sector, is we're seeing a lot more severe obesity. I remember even in our clinics, clinical wards, if you went there, you'd occasionally see someone with a BMI of 50. Today, I was just at clinics last week, and out of the 15 patients I saw, I think there were 8 of them who had BMIs over 60. So we're seeing a lot more severe obesity. And I think one of the reasons, and perhaps the key reason why we're seeing a lot of more severe obesity than we ever saw before, is that we've recognized the problem, but we're not offering treatments. We're not actually doing anything about it. Like, we look at this, and then we tell people to lose weight, and then we hope they do that, and then actually a lot of them do it. They go out and lose weight, and then they put the weight back on. And the problem just keeps getting worse and worse and worse because we're not actually providing treatments. So if you say it's a chronic disease, then the question is, well, then where are the treatments? What's happening here? Which brings me to one of the things that we are very excited about at this meeting, and that is that we're actually releasing today at this meeting this treatment report card. We have copies in English and French, and there's going to be copies out there. There's an infographic that you can get. Some of you would have already seen this appear in the media today because the report was embargoed until this morning, and since then I've probably done 15 interviews or so, and I know many of you folks who are in the room have probably done interviews across Canada. Lots of interest in this. So what is the obesity report card on the treatment for obesity for adults in Canada? So what this basically looked at, and this was a year-long project, was to look at province by province, health authority by health authority, trying to be as granular as possible to find out what are the kind of treatments that Canadians have access to when it comes to obesity in the public healthcare system. Now, we know there's a lot of private providers out there, and there's a lot of private programs, and some are great, and some might not that great. But when you look at obesity, as a chronic disease, and ask yourself, well, where does a Canadian who has obesity go for help in the public healthcare system? That's really what the point was. So what we did was we looked at the practice guidelines, said, okay, what are the recommendations in the practice guidelines? We talk in those guidelines about interdisciplinary care, team-based approaches. We talk about the use of special nutrition programs, dietary restrictions that have special indications. We talk about the use of medication, and we talk about access to bariatric surgery. That's all in the guidelines. Question is, can Canadians actually access those treatments? And so in this year-long project, we went across Canada, looked at all the websites, looked at all the programs. Talked to a lot of people. Mayank Rahani, who's in the room, who did this work, this was a full-time job for about a year or so, did a fantastic work of compiling this data. And I can tell you, it was not easy to get a lot of the data that you'll see in the report. The bottom line is, when we start with saying, the Canadian Medical Association says obesity is chronic disease, well, has that trickled down to the ministries, especially to the provincial ministries, who are ultimately the gatekeeper to healthcare in the different provinces. So you look at their websites, you look at all of the published documents that come out of ministries. What's the language that they use, or what's the narrative that they have when they talk about obesity? And what we found unanimously across the country, there was not one single ministry of health or wellness or any government document that we came across in which there was the language of obesity as a chronic disease. There was a lot of risk factor kind of thing, and there was a lot of wellness and healthy weights and lots of that kind of language, but there was no document that we came across from any government, provincial or federal, that actually recognized obesity as a chronic disease. And that has, of course, a lot of implications for how you think about obesity and whether you provide those services or not. The second finding was that when it comes to access to specialists for obesity or interdisciplinary teams for behavioral interventions, they're virtually non-existent. There's a couple of them every now and then. You find them around the bariatric surgical centers. There's a very few standalone clinics that offer this. I think it's fair to say that there are regions that dabble in this, but there is absolutely, at least we could not find any systematic plan to roll out chronic disease management programs for this chronic disease, obesity. So apparently it's almost non-existent. We looked at medically supervised weight management programs with meal replacement. Again, very often these are at bariatric centers, of which there are a few now, but there's a cost to patients, and the cost can be anywhere up to $2,000 for patients. So you can imagine, if you think about the demographics of people who actually have this disease, this is not easy for them to find that kind of funding. When we look at access to prescription medications, you might know that there are now 2 prescription drugs in Canada approved by Health Canada for the treatment of obesity. It turns out that very few Canadians have access to those drugs. Most benefit plans do not cover those drugs. None of the federal plans or none of the public plans cover any of the obesity drugs, which then led to the score on the report card. Basically, it's an F for access to medications for virtually every province. Number of bariatric surgeries. As all of you probably know, bariatric surgery is now the accepted evidence-based treatment for anyone who has severe obesity. And I think the good news is that over the several past years, we have seen a quite significant increase in the number of bariatric surgeries, which is probably good news. But when you put this in relationship to the number of people who actually need surgery or would qualify for surgery just based on BMI criteria, if you have BMI class 2 plus comorbidities or BMI 3, then what you see on the slide here is that access is actually not that great. In fact, overall in Canada, less than 0.5% of people who would qualify for bariatric surgery can access bariatric surgery per year. Less than 0.5%. And what you can also see on the slide is this huge disparity in access. So if you happen to live on Prince Edward Island, forget it, because there's not a single bariatric surgical program on the island. If you happen to live in Nova Scotia, you're talking 1 in 1,300 patients who would qualify for bariatrics who can actually access this. That's Nova Scotia. If you go more or less next door to Quebec, it's a 1 in 90 access. That's a 10-fold difference in access to an accepted evidence-based treatment. There is no other disease that I can possibly imagine where you would have a 10-fold difference in access to care from one province to the next. Now, we can spend a lot of time thinking and talking and discussing why that might be the case, and that and I'm sure that will be discussed in some of the sessions here. But clearly, there's a problem here. This is not acceptable. I mean, if you look at Alberta and Saskatchewan, in Alberta you've got a 1 in 300 chance. In Saskatchewan, it's a 1 in 800 chance. Massive difference. Why? And how do you change that? So, very eye-opening findings. Even in the provinces where you do have access, the wait times can range anywhere from 2 years to 5 years to they're not even being documented anymore. Like the wait list is closed. You can't even get on the wait list because they're not even accepting referrals anymore. That's how long the wait is. So again, when you look at the criteria, every single province gets an F, with the exception of Quebec that barely scraped by and just managed somehow to get a D. Nobody gets a B, C, or A. That's not even remotely there. So based on the findings of the report card, there is a call to action, and that is, the first one is, if we want to get serious about obesity treatment, we have to apply the chronic disease model to obesity in the same way that we apply to any other disease. I think one of the main reasons why we don't have these services in place has a lot to do with bias and stigma, which is, of course, something that the Obesity Network has always taken very seriously. I think employers, public, and also private payers have to look at how they plan to provide access to treatments that are evidence-based and actually work. There seems to be a dire need here for training health professionals, and again, CON is very active in that area. Building capacity for interdisciplinary healthcare services for obesity management, I think we're basically at ground zero for that. And I think it's also about time that we got a new version of the Canadian clinical practice guidelines. The last time those were published was back in 2006, which means they are now 11 years old, and a lot has happened in obesity management in 11 years. So I think it's time for that, and there is, in fact, a process now that has just been kicked off, where hopefully we will have updated guidelines in the next, hopefully next couple of years. Okay, so having said all of that, the question is, why do we have these barriers? And that brings us to this study. This is a study that is funded by Novo Nordisk, and it's being run across Canada. It's about to launch. And the goal of the action study is really to try to figure out what the barriers are. So the aim of the study is to figure out, why do Canadians not have access to obesity treatment? So the finding in the report is there is no access. The question is, well, then why not? So this is going to be a study that is going to look at barriers at the level of the patient. Why do they not seek out or get obesity treatments? We'll be looking at the professionals, to say what are the problems in the system that is providing those care, health professionals' attitudes towards obesity management, etc. But we will also be looking at employers and their attitudes, because the employers are the ones who contract out for the benefit plans, and then the benefit plans can choose to cover or not cover obesity management. So this is going to be really interesting, because I think it's absolutely key that we understand what the barriers are and why it is that we are in this very dire situation that 7 million Canadians who have this chronic disease have virtually no access to treatment. Okay, having said that, we have another little issue here, and that has to do with the actual definition of obesity. So obesity, conventionally, we've always defined as body mass index, but anybody who works in the field probably by now has realized that that's actually not a very good definition, especially if you're trying to diagnose a disease. It's fine if you're doing population studies and you're doing screening, population screening, maybe it's okay. But if you're using BMI to make it medical diagnosis, where the consequence then can be that that patient actually requires medical treatment, then you better make sure that your diagnosis is accurate. And unfortunately, we know that BMI is not accurate, because you will find people who meet those BMI criteria who are perfectly healthy. But we also know that there's people who fall beneath those BMI criteria who might very well benefit from obesity treatments. So this is a discussion that's happening not just in Canada now, but it's happening at the level of the Obesity Society. In fact, it's even happening at the level of the World Obesity Federation, where we're now starting to very seriously question the use of BMI as a diagnostic criteria or the defining criteria for obesity. So having said all of that, I want to come back to welcoming all of you to the summit. I'm sure it's going to be a very exciting few days, and I wish I could tell you enjoy Banff, but I know there's not going to be a lot of time for that. So I do hope that you're going to be tagging on a couple of days after the conference to really enjoy the outdoors, because I can tell you these are great outdoors. Okay, I did mention the Public Engagement Committee and the fact that CON is now reaching out to the public and saying, okay, and giving an opportunity to Canadians living with obesity to really become involved in what goes on about their disease, if you want to say. And so it's really a great pleasure for me to introduce Marty Enickson, who's the chair of our public engagement committee. Some of you might actually recognize him because he's become a bit of a star, largely because he was one of the first volunteers for CON's now famous image gallery. And I say famous because it's internationally famous. I was recently at a conference in Germany, and I saw Marty on a slide that was being shown by one of the people. So we have a real international star now amongst us, who's also the chair of our public engagement committee. Just a little bit of background. Marty Enickson lives in Edmonton. He works for the Alberta justice system. He's been involved as a patient advocate, as a very enthusiastic patient advocate for CON for a number of years. He's one of our standardized patients, so when we do certification courses and we say, okay, we need a real-life patient person, well, who better than someone like Marty who's been living with this for a long time. So his volunteer work with CON, he has been participating in educational events. He's been our standardized patient, and he's modeled for the image gallery, and he is here now today to tell you a little bit about his story and about the work that the Patient Engagement Committee is doing. So Marty, can I ask you to come up here? Big round of applause for him.
Oh my goodness. Welcome everybody. I don't use pictures. I never use pictures, so there's no slides. So you get to look at me and enjoy me. Thank you. My name is Marty Enickson, and I am a patient advocate, and I'm so incredibly honored to be here with you all today to share my journey with you. I'm an outspoken individual when it comes to speaking about obesity, especially as it relates to weight bias and weight discrimination. I am currently the chairperson of the Canadian Obesity Network Public Engagement Committee, and it is an honor to be that. But I am not just the patient committee, the Public Engagement Committee. I would ask right now that the Public Engagement Committee stand and be seen so that you all know who we are. Ian Patton, Jody Craw, Lisa Schaefer, Alex Schwarzer, Kelly Moen, Brendan Goodman, Ryan Drummond, Adriana O'Regan, and Catherine Taylor. These 10 people, they make up the Public Engagement Committee right now, and we are all very, very honored to be able to be here at your conference to share our journeys and share our perspectives as patients with you, and to be considered, as Mary Forhan has said so many times, as colleagues and not just the patients. So thank you guys for being here. I call this presentation My Dark Journey with Obesity. And before I get started, I wanted to ask you all some very simple questions, important questions. Please just ponder over these questions, think about them in your mind, and hold on to your answers. How many of you here today that are gathered have ever made fun of a fat person, or laughed at a fat person, or called a fat person names, or made a fat person feel like they are less of a human being because they are fat? I stand before you today, a 50-year-old man who currently weighs 380 pounds, a far cry from the highest weight of 505 pounds, which I achieved a little over 8 years ago. I had bariatric surgery in January 2009, a surgery that would assist me in losing weight so that I could have a quality of life again, a surgery that saved my life. Over the course of the last 5 years, I have spoken many times about my struggle and my journey with obesity. I have told my story, but I have always shared the journey from an adult perspective. I've never really shared my adolescent experiences with obesity. Today is different. Today I've decided to share the whole journey, including sharing with you what I consider to be the most painful part, my teen years. my time between junior high school and high school, my time between the ages of 12 and 17 years, a time that is supposed to be filled with amazing memories, but not for me. A time when I so desperately needed help, and yet there was no help for me. Let me tell you, if I could completely erase a period of time in my life, I would erase grade 7 to grade 12. It was so incredibly hard, you couldn't possibly imagine. I've only just begun to share the following information in my presentations, so please bear with me. It is incredibly hard to think about. However, I feel that it is incredibly important to speak about it because I think that we all need to understand how complex the disease of obesity is and how someone begins the journey to obesity. I believe that I will show each of you that it is not a conscious choice for someone to become obese. There are many reasons that obesity afflicts the population of the world. I point out that this is my journey into the dark world of obesity, and every journey is a little bit different for every person. I come from a family of 5 siblings. I am the second oldest, but was considered the middle child. I had an older brother, older by 1 year, and I had triplet siblings, 2 sisters and a brother. They were 3 years younger than I. My older brother and younger brother took after their fathers. My sisters and I took after my mother. My mother was an incredibly overweight woman herself. She struggled with her weight all of her adolescent life and her adult life. My 2 sisters and I also struggled with obesity throughout our adolescent years and into adulthood. In fact, the 3 of us continue to struggle with weight today. My mother ruled her house the way that she knew how. There was physical abuse, there was mental abuse. My mother enjoyed living in chaos, which meant that we all lived in chaos. When she loved, it was usually with food. We ate a lot of foods that were rich in fat or often cooked in fat. Foods were often high in sugar, and we didn't know what brown bread was in our house. Soda was very common when I grew up. In fact, soda would play a significant role in my journey with obesity. At the age of 12, I was struggling to fit in. I was bigger than my older brother, but I was physically weaker than he was. Between the ages of 12 and 17, I suffered a series of traumatic events at the hands of my older brother. During the above-noted period of time, my older brother repeatedly sexually assaulted me. The sexual assaults continued for nearly 6 years until he finally moved away from home when I graduated from high school. He had my silence because he threatened that he would tell everyone at school. We went to the same school. He was 1 year ahead of me, and he had friends, and he was popular, and he had the looks, and he had the physique, and I did not. I was socially awkward. I was already struggling a little bit with weight. I was the outcast. I remember that first time that he forced himself on me like it was yesterday. That day caused a ripple effect that would forever change the course of my life. It was the beginning of my journey and my struggle with obesity that continues to this day. Soon after the assaults began, I changed. I could tell no one about what was happening. I didn't know what to do. In the beginning, I thought that this was what brothers did. But it was always in secret, and eventually I learned that what was happening was wrong. As time moved forward, my brother became mean. He was a bully. He terrorized me. Along with the sexual abuse, he would abuse me mentally, verbally, and physically. I didn't know what to do. I became withdrawn. I became quite sad. I was depressed, although I didn't know it at the time. I could tell no one, but then again, I don't think that my parents even realized that there was anything wrong. I turned to food for comfort. I would eat and eat and eat. I would eat 3 helpings of supper, and then I would sneak food down to my room. Heated bologna and cheese sandwiches every night, 2 of them. I ate to take away the miserable pain. I was 13 years old, and I was in such pain. The only thing that brought me any comfort was food. As I ate more and more food, I began to gain weight. My clothes were slowly getting tighter. I was getting bigger. But Mom said nothing. She didn't stop me from eating. Each day I would dread waking up to face another day. There were times when I truly wished that I would just die. The sexual assaults continued. It was already hard, so hard at school. I didn't really have any friends. No one wanted to hang out with the chubby kid, the awkward social outcast. I tried so hard to fit in, but my brother made certain that my life was miserable. He would lead the charge, calling me every name that existed. Because he would do this in front of his friends started calling me those same names. And then the kids in my classes started calling me those names as well. I would come home from school, I would go down to my room, my safe place, and I would cry. And I would wait for dinner, because dinner would bring me comfort. And after eating a massive supper, I would walk to the corner store, and I would buy a Coke, and a bag of chips, and a chocolate bar, and I would bring them back to my room. I'd close the bedroom door, and I would lie in front of my television, and I would find comfort with my goodies every single day. Then an hour or so later, after eating my goodies, I would go up to make my lunch for school. 2 sandwiches, and I would make 2 sandwiches extra to sneak down to my room. And I would eat those sandwiches, trying to take away the pain that I was feeling. I never went to my junior high school prom. I hated junior high. I was so incredibly miserable. I was well over 200 pounds now. I was 14 years old. As I passed from junior high to high school, I saw less and less of my brother. But the damage was done, and the abuse was secretly continuing at home. I continued to gain weight. By the time I reached the beginning of grade 12, I was 17 years old, and I was 300 pounds. I was the spectacle. I continued to be on the receiving end of many jokes and pranks, and I endured being called names on a daily basis. Hell, I had very invented tormentors who created new names for me. I avoided the jocks as much as I could. They were the worst. They loved to pick on the fat kid, call me names, make me feel like I was less than human. There was mental abuse, there was physical abuse. I endured many physical assaults during my teen years. I was taunted and teased mercilessly. I wished every night that I would not be fat in the morning, that I would wake up and it would be over. But it was not to be. I was so tired of being fat. I honestly didn't know where to turn. I had tried all the fad diets that were out there. I had no success. I had tried the Jane Fonda workout. How many of you remember the Jane Fonda workout? Didn't work. I had sweated to the oldies with Richard Simmons. How many of you sweated to the oldies with Richard Simmons? I did. Didn't work. I pedaled my ass on a stationary bike for months. So much weight loss craziness, but I had no success because I was still eating out of control to hide my pain. Every night, I so desperately needed help. My mom and my sister were having success with diet pills, so I asked my mom to take me to her doctor. I so desperately wanted to lose weight too. Her doctor gave me the diet pills. I took them for 5 months, and during those 5 months, I lost 70 pounds. Can you believe that? 70 pounds. This is a miracle. I was elated and so happy that I lost the weight, but the downside was that I wasn't eating anything at all. Every time that I found myself eating food, I believed that it was going to cause me to gain my weight back. So I would have my mom take me back to my doctor, my trusted doctor, time after time, to get me stronger doses of the diet drugs so that my appetite would be completely suppressed. And let me tell you, was it ever suppressed? I wasn't eating out of control anymore. Heck, I wasn't even eating at all. I wasn't sleeping properly, and I wasn't thinking properly. School became really hard. I couldn't concentrate. I was a mess. I was frenetic, and I was out of control, and then I crashed. What did I expect? I wasn't eating, and well, you sort of need to eat food to live. And all the while, during this diet pill craziness, my mother did not stop me. In fact, she encouraged me, because she always took me back to the doctor for stronger meds. I realized somehow that things were out of control, and that what I was doing to me was not good for me. I had become a prescription drug addict at the age of 17 years, addicted to a form of speed so that I could lose weight. How incredibly crazy is that? These are the things we do to lose weight. At the 5-month mark, I stopped taking the diet pills cold turkey, and when I stopped, my suppressed appetite returned with a vengeance. I had starved my body for so long, and it wanted to feed. I literally could not stop eating. I was eating to bring myself comfort and take away the pain. And while I was eating, I felt so incredibly good, euphoric, in fact. And then as soon as I was done eating, I would feel like crap again because I had eaten. And then I would become depressed. So I would eat more food so that I'd feel good again. And then when I was done, I'd feel like crap again because I had eaten, and so I would eat again. It's a vicious circle that was spinning out of control. By the time I graduated high school, I had gained back all 70 pounds that I had lost, and as an added bonus, I also gained an extra 50 pounds. I was 17 years old, and I weighed 350 pounds. I attended my graduation ceremony, and I walked across the stage in my grad gown that didn't fit me because they didn't have one for a person of my size. I did not go to my prom. After I graduated, my brother moved out, and the sexual abuse was finally over. But the damage had been done. In less than 6 years, I gained just over 200 pounds, an incredible amount of weight gain in such a relatively short period of time. After graduating high school, I settled into the realization that I was going to be a big man. My life started to change. I couldn't purchase clothes in regular stores. I couldn't do things that others were doing. I never thought that I would get any bigger or heavier. Boy, was I wrong. My eating was still out of control, and my consumption of soda had increased exponentially. At its worst, I was consuming about 15 liters of Pepsi Cola each and every day. I drank Pepsi like most people drink coffee. I started my day with Pepsi. I ended my day with Pepsi. I ate copious amounts of junk food, potato chips, and chocolate. They were my go-tos. They were the things that I knew would bring me comfort. In time, 350 pounds became 400 pounds. Then 400 pounds became 450 pounds. On January 7, 2005, or July 7, 2005, my apologies, my life changed forever. I was 38, I was 475 pounds, and my proverbial kick in the head happened. I was attending the gay rodeo in Calgary. I was dancing with friends, and I suffered what my family doctor eventually classified as a mini-stroke. Some would say that my luck was not on my side. However, I would disagree. I called it my wake-up call, and it was what I needed at that point in my life. I returned to Edmonton and worked up the courage to go visit with my family doctor. He promptly put me on meds for high blood pressure, type 2 diabetes, heart disease, and a myriad of other issues. Before my bariatric surgery in January of 2009, I would be on 14 different medications, taking up to 50 pills a day. There would be endless appointments with my regular doctor and with specialists. Heart doctors, diabetic doctors, and I would endure tests, and more tests. Some tests I could attend to, and some tests were more problematic. Because I was so big, some medical testing facilities in the city didn't want me on their machines for fear that I would break them. I remember when they told me, that medical technician at the Royal Alexandra Hospital, "You're too fat for our machine, and we don't want you to break it." I was speechless. I couldn't go for an MRI where I lived in Edmonton because I was too fat. The only machine that could hold me was 300 kilometers away in Calgary. It was my wake-up call. I listened to my doctors and desperately tried to make changes. I talked with them about bariatric surgery and whether that was a viable option for me. My doctors sent letters to the Weight-Wise Clinic seeking to have me admitted. I was told it would be a long wait to get in, as the list was very long. I said that would be fine, and that I would start up by changing my diet and getting daily exercise. Eat less and move more. It's what all the doctors keep saying. I was going to try to do this on my own without surgery. I cut out my 15-liter-a-day Pepsi habit. I dropped the junk food, changed my foods that I was eating, and I began walking. I would walk an hour a day, every day. Eventually, I'm walking about 4 miles per day. Unfortunately, carrying around 475 pounds was becoming harder and harder, and I finally was put on Oxycontin. In the 2 years that I was taking Oxycontin, I went from starting at 10 milligrams up to 3 times a day to taking 40 milligrams 4 times a day. This was necessary for me to continue to work and do my job and get around. The pain in my knees and in my hips had become almost unbearable. I knew that I was now on a path that would certainly lead me to my destruction. I spun into a depression because my attempt to become a little bit healthier and lose some weight had backfired, and now I was in extreme pain because of it. On July 16, 2007, 2 years after my mini-stroke, I finally got in to the Weight-Wise Clinic. My first appointment, and so began my journey. There was hope. I had an amazing team of health professionals working with me while I was on this journey. Incredible supporters who only wanted me to do my best. October of 2008, I had now reached my top weight of 505 pounds. A quarter of a ton. Any of you drive trucks? Half-ton truck? It's a quarter of a half-ton truck. I was about to turn 42 years old. I had been accepted into the Weight-Wise program 18 months earlier, and in that time I had some great successes and highs, and I also had some great failures and lows. On Tuesday, January 13, 2009, Dr. Birch and his surgical team set out to literally save the life of a man named Marty Enigson. I finally received the life-saving bariatric surgery that I so desperately needed, and I lost 150 pounds. Over the course of the last 8 years since my surgery, I've continued to struggle with my weight. Every single day is a struggle. The surgery made my stomach smaller, but it didn't change the fact that I still look to food for comfort. I've learned that I can't do that, but that is my struggle, something I deal with all the time. My journey has been rocky, up and down battle with weight, which has seen me lose and at times has seen me gain. Ultimately, I know that I will work incredibly hard to never, ever be where I was on October 20th, 2008, at my top weight of 505 pounds. I am not that man anymore. I am now about 380, and I'm a much happier person. But you know what? I'm still considered a morbidly obese human being. I've learned over the years that success with bariatric surgery is three-pronged. There, of course, is the surgery itself. It is not the quick fix. It is not the easy way out. You can't have the surgery and think that you will lose all the weight and become skinny and eat everything that you want, and you'll end up stretching out your stomach again. You must have to understand that in conjunction with the surgery, you change your eating habits, and along with changing your eating habits, you must couple it with some form of movement. It's a lifestyle change, and it has been exactly that for me. It came down to a basic decision. Either get busy living or get busy dying. I'd already been very busy on the path to dying, and I didn't want that, so I decided instead to get busy living. And living is what I do now. Each and every day, there has been incredible emotional highs, and at the same time, there have been incredibly emotional lows. I would describe my journey with obesity as a never-ending roller coaster ride, one that I will ride for the rest of my life, because obesity is something that I will live with and struggle with for the rest of my life. I have no regrets, and I wouldn't change things at all if I was given the chance. I believe that everything happens for a reason. I really do, and I believe that the path that was chosen for me was meant to be experienced by me. I believe that I had to endure the abuse and the experiences that I have so that I could stand up here today and speak out and share with others what the lived experience is for somebody who lives each and every day of their life with obesity. I am a hardworking, productive member of society, a professional, a paralegal in the criminal justice system in Canada. I am also a disc jockey and have DJ'd for over 30 years now. I am a single father of 2 children. I am educated. I am not lazy. I work out frequently. I am not a glutton. In fact, I probably eat less every single day. I eat less than most of you in this room. I am a human being who hurts, who has feelings, who sees and hears the injustices and insults that are flung and hurled towards people who are living with obesity. Hell, I continue to be on the receiving end of those insults. I'm a human being who wants to see a change, a human being who wants to see the terrible disease called obesity conquered in this century. Before I die would be great, please. Obesity is a very complex, challenging, mental and chronic disease that currently affects more than half of the world's population, including a great many children. In fact, I believe wholeheartedly that each and every one of us in this room and beyond has a stake in this. I believe that every one of us in this room knows someone who suffers from overweight or obesity. It's statistically impossible not to know someone. How many of you have a family member, a mom, a dad, a wife, a child, siblings, an aunt, an uncle, grandparents, a cousin, a best friend who suffers from obesity? I bet you all do. Now I'm going to circle around and bring it right back to where I started from. I ask you again, how many of you have ever made fun of a fat person? Are you daring enough to put your hands up? More importantly, how do you think your overweight or obese family member or friend would feel if they knew that you had made fun of overweight and obese individuals? Think about that the next time that you see a person living with obesity and you want to make fun of them or make a comment. Remember that you don't know how they got there, and you have no idea what their incredibly horrible journey has been like for them. Together we can make a difference and effect a change. You can start today, everyone in this room, by signing up to become a supporter of the Public Engagement Committee. Are you ready to stand up and speak out and make that change, one person at a time? Thank you, everyone.
Yeah. Well, that took a lot of courage. That was very brave. But those are the kind of folks that we have in our Public Engagement Committee. And it might sound like a single story, but I can tell you every single person on our Public Engagement Committee, in fact, hey, every single patient I see in my clinic could tell you a story that's as powerful. And all of us who work in obesity, whether it's prevention, whether it's research, whether it's policy, whether we're studying fat cells or appetite or neuroregulation, let's never forget the people that we're here to serve. They're people like Marty. And we can only wish that Marty would have received the care that he needed when he was 12 years old, when he was 13 years old, that there would have been a clinic that he could have gone to in the public healthcare system where there were qualified people who knew what they were doing. The Canadian Obesity Network actually did a survey of pediatric centers in Canada that have it, and I can tell you that in most provinces we still don't have pediatric centers that do this. When you talk about pediatric obesity, they tell you, oh yeah, we do prevention. Well, that's nice. What do you do for the kids who actually have the problem? Well, they shouldn't have the problem if we teach their parents how to feed them. I mean, that's the level of discussion and discourse that we often have when we talk about these things. It's now my pleasure to introduce Dr. David Macklin. He's representing the Canadian Obesity Network Science Committee. And I can tell you that the Science Committee has worked very hard putting this program together. If you don't like the program, blame them. David is a lecturer at the University of Toronto in the Faculty of Medicine, Department of Family Medicine. He's a University of Toronto trained family physician who also has a qualification as a psychotherapist. And he has committed his medical career, his professional career, to the prevention and treatment of obesity. He directs a multidisciplinary evidence-based behavioral weight management program, one of the few in Canada, if you want. He's the medical director of the weight management and lifestyle program at the Toronto MedCan Clinic. And he's also the medical director of the weight management program at the Toronto Mount Sinai Hospital High-Risk Special Pregnancy BMI unit. And he is, next slide, or if you can go back to the slides. He is going to introduce our distinguished lecturer, and he's going to tell you a little bit about him.
Thank you, Arya. Marty, thank you very much for your brave discussion with us regarding your history. I'm personally very moved and honored not only to be with the Public Engagement Committee here, but really in a room of professionals who also, like me, have committed their research time or careers to the prevention and treatment of obesity. But thank you very much, really, really very moving. Today I was going to introduce Ian Jensen. Ian, I'm very proud to say, is this year's recipient of the CON Distinguished Lecturer Award. Unfortunately, Ian is not here today. He's on his way from Kingston. I don't know, many of you may know that he focuses his research in the causes and health consequences of physical inactivity and obesity. And because of that, he decided to walk here and really miscalculated how much time that would take. And so we are going to meet here again at 5:30 tomorrow, where I'll be giving him the award pending a leg cramp that he's talking, making sure that works out fine. I am also today then going to read a letter from the Honorable Brandy Payne, the Associate Minister of Health in Alberta. Brandy says, it's my great pleasure to welcome you all to the beautiful Fairmont Banff Springs for the 5th Canadian Obesity Summit. As Alberta's Associate Health Minister, Minister of Health, I support the Canadian Obesity Network taking the lead in looking for solutions to prevent and reduce the incidence of obesity in our country. Our government is committed to working collaboratively with Albertans and healthcare partners like you to promote healthy weights and develop treatment strategies to help prevent obesity in Alberta. In fact, we recently declared March 2017 as Nutrition Month in the province of Alberta. Gatherings like this summit, which deepen our understanding, broaden our perspectives, and introduce us to new voices and ideas, are an important part of ensuring all Albertans receive the best possible health outcomes. Thank you to the Canadian Obesity Network and its many members of healthcare professionals, researchers, policymakers, and other health advocates, and the Public Engagement Committee for working tirelessly to improve the lives of Albertans and Canadians affected by obesity. Best wishes for an enjoyable and insightful summit. As a member of the Science Committee, I am very honored to welcome everyone here. And the concept that we are able to commit these days to a better understanding from whether it is research or neuroscience or what behavioral treatments can help or surgery, it's wonderful that we're able to bring all these great minds together and learn. I just mentioned, though, as a member of the Science Committee, a point that really just hadn't been mentioned yet today. And Arya will always say that, yes, it's great to learn here, and we all will. But one of the key benefits I would suggest for being here this week is networking. It's in our name. The concept is that we meet like-minded people with the similar interests and really can develop, whether it's our research or professional careers, or as public engagement committee members, really further the work that we can do going forward from here to help with our purpose. So don't forget to network, and I'll see you all again here at 5:30 tomorrow to welcome Ian from his walk and give him his award. Thank you.
Okay, well, it's a long way from Kingston. All right. Okay, so we do have a couple of minutes before we actually open up and have the welcome reception outside. I believe they're still setting the stuff up. So I thought we would use the gap that Ian has now put in our hands. So we will use it to our advantage. Now, one of the reasons we're here, all of us working in this field, is because we are advocates for the kind of work that we do, and we have all a role as just as citizens. I wouldn't even think professionally, but as citizens, we have a role to advocate, whether it's more effective measures for prevention of obesity or more effective or better access to treatments. And I think that advocacy is now front and center amongst the activities that the Obesity Network does. So in that sense, you're all advocates for being here. You've traveled far and wide. You've paid good money to be here. And so in the spirit of advocacy, if you want to be an effective advocate, you need to have a big mouth. Now, I'm going to call upon the biggest mouth in the room, Dr. Yoni Fruithof, who all of you know, who is really an expert on advocacy. And, I mean, he's tireless. And he's going to just share with us his opinion and his take on the role of advocacy and anything else he chooses to do. You can't actually control him, so there's no way that I can tell you what he's going to talk about.
So this is the not distinguished lecture. And thanks for hanging around, and thanks to Ian, I guess, for walking here, and thanks to Marty for, this is why we do what we do as far as advocacy goes. And I want to speak briefly to the report card that was released today that Arya was mentioning. And not so much the report card, but the responses to the report card. So without, I don't know who's gone online like I did and looked at the comment sections or read the stories that were in the news, but do you have a sense as to what the message you'd see in the comments about should we be treating obesity was like? Anybody want to guess? Yeah, so I heard something about weight bias. So it was bad, right? So the comments are predictable. The comments are eat less, move more. And not just from random internet trolls. So the National Post, I don't believe, have comments anymore. But of course, they seek commentary from other people when presenting one side of a story. They went to Kenneth Ogilvie, who's the senator who was actually in charge of writing that report that was shown at the very beginning. I testified for it. I'm sure others in this room testified for it as well. And here are some statements that he made to the National Post about this report card. Obesity, to be blunt, is very largely a lifestyle issue, Ogilvie said. And I read that, and I thought, oh, that's not good. And it got worse. So this is still Senator Ogilvy speaking to the National Post. So at some point, people have to take some responsibility for their own management. And obesity is one of those areas around which, with some initial medical advice and guidance, people do have the opportunity largely to manage it on their own. It's a really remarkable statement to come from a non-internet troll in the venue of a national newspaper in response to a report card about a condition that the Canadian Medical Association has determined to be a chronic disease. And it is weight bias, of course, that leads to this idea, this blame-based idea that because on paper, forks and feet can make this go away, this dogmatic, idiotic truism of eat less, move more is all you need to know, that these comments are the ones that the nation is seeing from their peers, from their friends, and from senators involved in health committees. And so I'm blogging about this tomorrow. I decided not to blog about the report, but rather to write about the responses to the report. And to give a bit of a preview, I want to talk about statins, so cholesterol-lowering drugs, high-dose statins in heart attack victims. So people who suffer heart attacks, one of the most clear recommendations as far as treatment goes is the prescription of high-dose statins that they are to take in perpetuity and that they've been shown to reduce the risk of recurrences. You would imagine that if we're talking about a motivated population, someone between the age of 65 and 74 who has just suffered a heart attack would be very motivated for behavior change, right? That is a very fundamental event. It is the kick in the head for that person. A study was done a number of years ago. It was published, I believe, in JAMA, and it found that of the people who had a heart attack who were between the ages of 65 and 74 and who had coverage, Medicare coverage for drugs, only 30% filled a prescription for a high-dose statin within 1 month of being discharged from their hospital stay for their heart attack. A study came out last week from JAMA looking at the 30% who actually filled this particular prescription. And the question was, after 2 years following a heart attack, what percentage of those people, that 30%, who filled their prescription were still taking it as directed, where their singular behavior change was taking a medication once per day? All this to say, and you can't statistically do this, but I'm going to do it anyhow, when you combine the two studies, 8% of patients between the ages of 65 and 74 who have drug coverage 2 years after a heart attack were still bothering with the behavior of taking a high-dose statin once a day. I bring this up because we are talking, if you want to believe that the forks and the feet are the secret to dealing with all of this, forks and feet, the amount of effort and change and sustained behavior change to actually achieve what Senator Ogilvy is suggesting anybody could if they just wanted to, is a far more dramatic amount of change than taking a pill once a day. And yet, a group of patients who are incredibly motivated, of that group, 92% can't take that pill every day. And I am not vilifying those people. I think that the human condition, we are not particularly great, any of us, at sustained behavior changes. We're not good at it. It's just the way we are. But denying people health care coverage because of a human condition that we are not good at is not what healthcare is about. Healthcare is not about blame, and healthcare is not about saying, because you couldn't do this. And when it comes to chronic non-communicable diseases, of which obesity is one, most of them are treatable and preventable by way of lifestyle changes. But we don't moralize about anything other than obesity. You know, high blood pressure is the most obvious example in my mind. High blood pressure responds to dietary changes, to exercise, to sleep, to all sorts of things. But if a patient goes into a doctor's office, they don't even necessarily bring up the changes. It's, oh, well, we can just prescribe you this medication, because that's what we're supposed to do in medicine, is provide treatment options and administer them as best we can. And so all this to say, we were talking about advocacy. This is a room filled with wonderful people, many of who have the privilege of having initials after their names. Whether it's RDs, MDs, PhDs, OTs, PTs, I'm sure there's initials I'm leaving out, RNs, RPNs, PSWs, SWs, MSWs. Initials are valuable when it comes to getting attention, whether it's deserved or not. Initials help people to be heard. And sometimes I lecture to medical students or to residents about, I think, what one of the major failings in medical education, I think, is not discussing the role of advocacy, of leveraging those initials to speak about things you care about. You know, in this room, it might be about advocating and calling up your MP or MPP in response to this report, in response to Senator Ogilvy's comments, and just leaving them a note to say, hey, this is not okay, this is why. It doesn't need to be long. It can be a phone call. It can be an email. It can be a letter to an editor. Maybe it's in an area related to healthy living as a whole. As a father of 3 kids, I'm fighting for them on a fairly regular basis with, you know, their dance school that's giving out lollipops at the end of every lesson. And instead, I showed up with a whole pile of stickers and suggested that maybe you could give these out instead, and I explained why. All this to say, though, is that I think we need to do a better job. It's wonderful we tell each other all the things that we agree with. It's a lovely echo chamber that we have. But I do think that it is worthwhile, and I think it is part of the responsibility of the people who clearly care enough to come to a conference like this to occasionally, you know, get their feet wet with making those phone calls, writing those letters to the editor, speaking to their school boards. You know, it doesn't need to be confrontational. I'm not suggesting that that's what I want people to do, is to yell and scream and say you're wrong. In fact, I would argue that's not the best way to go. But pointing out contradictions, pointing out errors, pointing out needs, well, our initials help us to do that. And so my ask today is if everybody can consider doing that for one area of their lives over the course of the next week or 2, and then seeing how that goes and continuing to consider whether or not your voice might make some difference, I think that would have a lot of value moving things forward over time. And I think we're good for time, and that was your non-distinguished lecture.
Yep, I knew he could do it. All right, so as you might have noticed, this year the summit has gone green, or partially green. We're on our way to going green. We've already made the move to getting healthier snacks and stuff, and you're going to see that around, but we've been doing that consistently over the past few meetings. But now we're deciding to go green. So that's the reason why most of you will not be getting copies, printed copies of the program. The program, if you've had a chance to look at it, there's a lot of program. Right? There's like 200 talks and 48 plenary lectures and whatnot. I mean, the Pecha Kuchas, I can only tell you, we tried the Pecha Kucha experiment at the World Obesity Conference that Con co-hosted last year in Vancouver, and it was actually a pretty remarkable success. Those of you who don't know what Pecha Kucha is, so basically you get some poor fellow, give them 6 minutes, and then they have 6 minutes, and they have these slides, and they have to get through them. They don't get an extra second, and that's it. So what we've actually done is we've selected some of the top abstracts that were submitted for this meeting, and we've challenged them to present them in a Pecha Kucha style, and they will be presenting those not in some room that's hidden away somewhere as normally happens with these original presentations, but actually here to the plenary. So there will be, after the plenary talks, there will be selected abstracts, those abstracts that were deemed as being top-notch by the Abstract Review Committee, will be presented Pachacucha style. I know the folks in the room who have to prepare for this are nervous. It is challenging, but it's going to be a lot of fun, which is really what this meeting is about. It's basically fun. You got to network, have fun. So we don't have printed copies, which means you get to download the app, which I'm guessing you've already done. If not, it's somewhere. Virtual space, you can download it. I also would be amiss to forget to remind you that there are social events. There are lots of social events. You don't have con meetings without social events, and those social events are fun. I can tell you that. I think tomorrow the social event is at Wild Bill's, which is, for those of you who are not from Western Canada, your chance to show off your newly acquired cowboy boots and cowboy hats, and I think there's a bull that you can ride. But mainly it's a networking event. I mean, there's going to be beer and stuff, and so just show up. You've got tickets for that in your bag package. If you don't have a ticket, just ask. I must compliment the students and new professionals on organizing that. That's one social event. The other social event that we have is going to be the Rose and Crown. Those of you who regularly come to Banff know the Rose and Crown. Needs no introduction. Those of you who have not been to Banff before will know the Rose and Crown by the time you get out of here. So that's the other social event, and I do encourage you to come to those events. They're going to be lots of fun, and they're part of what this meeting is about. So having said all of that, once again, welcome. Thanks to all the organizers. Thanks to all the sponsors. Thanks to all of you for making the trip out. Thanks to Ian, who's hopefully finds his way to Banff. And I can now invite you to the reception that's outside in the hall waiting for you. Thank you.